Hi friends, this is Varsha MBA, working as Assistant Professor in the Department of Pharmacology and Shri Adichinchangiri College of Pharmacy. Today I'm going to discuss about diuretics. So we have to discuss about definition, classification, mechanism of action, pharmacokinetics, adverse effects, and therapeutic uses. The definition of diuretics, these are the drugs which will increases the rate of urine formation, causing a net loss of solute, that is mainly sodium chloride, and also along with equivalent volume of water by interfering with transport mechanism responsible for the reabsorption of solute from various segments of the nephron. So these are the drugs which causes a net loss of sodium and water in urine. So these are several categories of diuretics. All diuretics increases the excretion of water from body, and also there is a term natriuretics that will be called as a substances that promotes the renal excretion of sodium. So diuretics are very effective in the treatment of edema, means congestive heart failure, pregnancy and nutritional, and also nephrotic syndrome, diabetic insipidus, hypertension, cirrhosis of liver, and also the lower the intracellular CSF pressure. The introduction, the kidney, which will be having 0.5% of the body, and which will be receives 25% of cardiac output, that is 50 times. Each kidney contains 1.3 million nephron. The functions of the kidney, that is balance of electrolytes, plasma volume, acid-base balance, activation of vitamin D, synthesis of erythropoietin, urokinase, and excretion of urea, uric acid, and creatinine. Mechanism of urine formation, that is glomerular filtration. There are three mechanisms, that is glomerular filtration, tubular reabsorption, and tubular secretion. In the glomerular filtration, receives 25% of cardiac output. Filtration rate is 100 to 120 ml per minute and 180 liters of glomerular filtrate per day. So tubular reabsorption, that is reabsorption of 99% of glomerular filtrate only, that is 1 ml per minute excreted as urine. That is 1.5 liter per day of urine will be excreted. So the excretion of the kidney is dependent on glomerular filtration, that is tubular reabsorption. So amount of filtrate that will be absorbed, that means which will be amount of reabsorbed, and also amount of secreted, that will be called as an amount of solute excreted. So nephron parts and characteristics, that is this is a nephron, and this is having the glomerular filtration, the tubule, that is which will be cause for the tubule reabsorption secretion, that will be in the proximal tubule and distal tubule, and the glomerular filtration which will be in the afferent arteriole, Bowman's capsule, and afferent arterioles. So proximal tubules, that will be reabsorption of 60 to 70%, that is sodium, permeable to water and isotonic urine. Then active absorption of sodium chloride, glucose, amino acids, and organic solutes. Loop of Henle, that is thin descending limb, that will be most active, water will be reabsorbed. Then thick ascending limb, that will be absorption of sodium and impermeable to the water. And distal tubule, that will be sodium reabsorption and also the calcium excretion will be regulated. Collecting duct, that is selectively water permeable. Coming to the classification of diuretics, that is high swelling or loop diuretics, thiazides, carbonic anhydrase inhibitors, potassium sparing diuretics, osmotic diuretics, and low ceiling diuretics. So coming to the, according to the site of action, the classification will be according to the site of action. The proximal tubule, that is osmotic diuretics, the loop of Henle, which will be happens in the loop of Henle and collecting duct, that is carbonic anhydrase inhibitors, and xanthine diuretics. Coming to the site of action on ascending limb of loop of Henle, that is loop diuretics. Then site of actions on distal tubule, that is thiazide diuretics, and collecting tubule, that is potassium sparing diuretics and ADH antagonist. The classification according to the basis of efficacy, that is high efficacy diuretics, inhibitors to the sodium, potassium, and calcium co-transport, that is sulfonide derivative, furosemide, bumetanide, taurusinide, phenoxyacetic acid derivative, ethylenic acid, medium efficacy diuretics, that is inhibitors of sodium and calcium, Simport, Benz thiazidins, that we call it as a thiazides, hydrochlorothiazide, Benz thiazide, hydroflumenthiazide, then clopamide. Then second classification in the medium efficacy diuretics, that is thiazide-like diuretics, chlorthalidone, metazolone, zampide, and indapamide. Then weak or adjuvant diuretics, carbonic anhydrase inhibitors, that is acetazolamide, potassium sparing diuretics, aldosterone antagonist, spironolactone, eplerenone, inhibitors of renal epithelial sodium channel, that is trimetrin, amiloride. Then osmotic diuretics, that is mannitol, isosorbide, and glycerol, xanthines, theophylline. So this is about diuretics, where that particularly the drugs which will be act on the glomerular filtrations. So in the cortex, that will be acetazolamide. So whatever the acetazolamide, osmotic diuretics, then thiazides and adenosine. This will be act on the cortex, and other in the outer medulla, that will be act on the osmotic. I mean whatever the mannitol, that is osmotic agents, and IDH antagonist, and also adenosine. This will be act on the outer medulla. The site and mechanism of action of diuretics, that is osmotic diuretics. Site of action is proximal tubule, loop of Henle, and collecting duct. The main mechanism of osmotic diuretics, that is inhibition of water and sodium reabsorption. In carbonic anhydrase inhibitors, site of action is proximal tubule. Then mechanism, that is inhibition of bicarbonate reabsorption. Then diuretics, that is loop diuretics, site of action is loop of Henle, that is thick ascending limb, and mechanism of action, that is inhibition of sodium, potassium, calcium co-transport. Thiazides, site of action is early distal tubule, mechanism is inhibition of sodium, calcium co-transport. Then potassium sparing diuretics, late distal tubule collecting duct, inhibition of sodium reabsorption and potassium secretion. Loop diuretics are active and loop of Henle, which will be in the thick ascending limb. Then, which will be example for the loop diuretics, that is furosemide. So, furosemide, it is a prototype drug and which is under the sulfonamide derivative, and it is most powerful diuretics. So, furosemide, the mechanism of action of furosemide, the furosemide, which will be entered to the proximal tubule by organic acid transport. So, which will blocks the sodium, potassium, calcium co-transport in the thick ascending limb. So, which will be competes with the calcium binding site and enhances the magnesium, calcium, sodium, potassium, and hydrogen excretion. It inhibits the sodium chloride reabsorption in the thick ascending limb. It inhibits this reabsorption of 25% of the glomerular filtrate. Then coming to the pharmacokinetics, the furosemide are administered orally. So we can administer through the oral route. So furosemide and the other loop diuretics are rapidly and almost completely absorbed. They are extensively bound to plasma protein. They are partially metabolized in the liver, and metabolites are excreted by urine. Adverse effects: hypokalemia, metabolic alkalosis, then hypotonia, and also hypouricemia. So also, which will be having some adverse effect, that is ototoxicity, hypomagnesemia, and hypocalcemia. Then uses, I mean therapeutic uses of furosemide, they are highly effective for the relief of edema for all the organic organs like cardiac, hepatic, or renal edema. Used in the treatment for acute renal failure, the furosemide is used as an alternative to or in combination with osmotic diuretics. Used for the treatment of hypertension, hypercalcemia, and hyperkalemia. The drug interaction, it may increases the ototoxic potential of aminoglycoside antibiotics, especially in the presence of impaired renal function. Furosemide combined with the angiotensin converting enzyme inhibitors, that is ACE inhibitors, thus may lead to severe hypotension. Then contraindication, pronounced hypothermia and anuria. Then coming to the thiazide-like diuretics, that is thiazide diuretics are active in distal convoluted tubule. Thiazides are medium efficacy diuretics. Chlorothiazides was the first thiazide to be synthesized. All thiazides have sulfonamide group. Mechanism of action, that is thiazides, reach distal convoluted tubule, bind to block sodium and calcium import system, increase the excretion of sodium chloride, also increases the excretion of potassium and magnesium, decreases the excretion of calcium and uric acid. So this is the distal convoluted tubule. So in the thiazide diuretics, sodium, calcium, and this all the things will be reabsorbed. Pharmacokinetics of thiazide diuretics. Thiazide are well absorbed after oral administration. Rapid acting within 60 minutes. Duration of action varies from 6 to 48 hours. These are excreted in urine. Adverse effect: hypokalemia, hyperglycemia, metabolic alkalosis, hyperuricemia, hypotonia, hypercalcemia, fatigue, anorexia, gastrointestinal disturbances, allergic reactions. Then coming to the therapeutic uses, thiazides are the first line drug for the treatment of hypertension. They are used for the treatment of CHF, congestive heart failure, hyperkalemia, hypercalciuria with renal stones can be treated with thiazides with reduced calcium excretion. Treatment of nephrogenic diabetic insipidus. Drug interaction, it combined with the distalis glycosides that induces the hypokalemia and hypomagnesemia and causes the distalis toxicity. It combines with the lithium and decreases the lithium clearance and causes lithium toxicity. It is contraindicated in pregnancy. They may reduce the maternal uterine blood flow. It also contraindicated in diabetes pregnant women. The carbonic anhydrase inhibitors, the next classification, that is carbonic anhydrase inhibitors. So these are active in proximal tubule and they are limited use of diuretics. Example, that is acetazolamide. It is also one of the prototype drug and it is under the category of sulfonamide derivative. Mechanism of action: acetazolamide binds to inhibits enzymes carbonic anhydrase and which blocks the sodium bicarbonate reabsorption. So this will be increases the excretion of sodium, potassium, and water. That is early proximal tubule. This is the mechanism of acetazolamide. So pharmacokinetics: acetazolamide is well absorbed orally. Onset of action is within 60 to 90 minutes. Duration of action is 8 to 12 hours and it is excreted in unchanged urine. Metabolic acidosis, hyperkalemia, drowsiness, paresthesia, that is nothing but pain due to pins and needles under the skin and skin rashes. Therapeutic uses: acetazolamide decreases the intraocular pressure, hence used to treat glaucoma, used to alkalize the urine. Acetazolamide is used mainly in prophylactic agent in acute mountain sickness. Acetazolamide is used as an adjunct in epilepsy. Drug interaction, which is combined with a warfarin, that is anticoagulant, which decreases the metabolism rate. It is combined with a 2,4-thiazolidone, which decreases the excretion rate. The contraindication, it is contraindicated in situation in which sodium or potassium blood serum level are depressed in case of liver disease. And coming to the potassium sparing diuretics, the potassium sparing diuretics may act by two ways, that is aldosterone antagonist, that is spironolactone, and one more way, that is inhibitor to the renal epithelial sodium channel, trimetrin and amiloride. Mechanism of action of spironolactone, that is enter the cell and bind to specific mineralocorticoid receptor in DT and CD cells, inhibit the actions of aldosterone and increases the sodium and water excretion and decreases the potassium loss. Amiloride and trimetrin, they block the sodium transport through the sodium channel in the luminal membrane, increases the sodium and water excretion, decreases the potassium loss. Pharmacokinetics of spironolactone, that is orally administered, spironolactone which can be administered orally. It is highly bound to plasma protein, completely metabolized in liver, converted to active metabolites. Amiloride, oral administration, that is 50% effective, not metabolized, not bound to the plasma proteins. Trimetrin, it is incompletely absorbed orally, partially bound to the plasma protein, largely metabolized in liver to an active metabolite and excreted in urine. Adverse effect of spironolactone: hyperkalemia, drowsiness, confusion, gynecomastia, hypotyroidism. Trimetrin: nausea, dizziness, muscle cramp, and photosensitivity. Amiloride: nausea, diarrhea, headache, and hyperkalemia. Therapeutic uses of potassium sparing diuretics. These are the used with the thiazides and loop diuretics for treatment of hypertension. The combination therapy increases the diuretics and hypertensive effect. They are used to treat the cirrhosis and congestive heart failure. To counteract potassium loss due to thiazide and loop diuretics. Drug interaction, it interact with lithium that may increases the level of potassium in the blood. It also interacts with ACE inhibitors, digoxin, and steroid like prednisone. Contraindication, it is contraindicated in the patients with hyperkalemia, Addison disease. Coming to the osmotic diuretics are not interact with the receptor or directly block the renal transport. Actively dependent on development of osmotic pressure. Example for osmotic diuretics, that is mannitol. It is a prototype drug and it is pharmacologically inert, so can be given in large quantities sufficient to raise osmolarity of plasma and tubular fluid. Mechanism of action of mannitol. Mannitol, which will be increases the osmolarity of the plasma, shift of fluid, that is osmotic effect, from the intracellular compartment, that we call it as ICC, to extracellular fluid. Extracellular fluid, that we call it as ECF. Then expansion of ECF volume, I mean extracellular volume, which will increases the glomerular filtration rate. Mannitol is freely filtered at the glomerulus. Increases osmolarity of tubular fluid, inhibits the reabsorption of water and sodium chloride. The net effect is increased urinary excretion of sodium, potassium, calcium, magnesium, and calcium. Pharmacokinetics, the mannitol is administered intravenously. It is neither metabolized in the body nor reabsorbed from the renal tubules. It is pharmacologically inert and is freely filtered at the glomerulus. Adverse effect of mannitol, that is hypothermia, pulmonary edema, headache, nausea, vomiting. Therapeutic uses of mannitol, it is used to reduce the elevated intracellular tension following head injury or tumor. It is used to both pre and post operatively to reduce the elevated IOP in acute congestive glaucoma. Mannitol is used to produce diuresis in case of poisoning. Mannitol is used to prevent acute renal shutdown in shock, cardiovascular surgery, hemolytic transfusion, reaction, etc. Drug interaction of mannitol. So it interact with depression, medications like E4 and Laxpro. It also interact with diabetic drug like Tanzium, the contraindication anuria, pulmonary edema, severe dehydration, intracranial hemorrhage. These are the references I referred from the book, that is Medical Pharmacology by K.D. Tripathi and also Padmaja Udayakar, and some pictures I referred from the YouTube. Thank you. Thank you.